Unmute that thing. Ha! Got it now, baby. So yeah, they're trying to keep this streaming schedule done so we can actually broadcast out. So they're like stick to the schedule, which is rough. I'm the moderator for this room too, so there's nobody there to show me 15 minutes. So I don't know how that's going to work out. But my name is Jordan Johnson. I promise you, I'll probably step on some subjects that are tough. I'll probably offend you. It'll be okay. We'll all have fun. My background, trained in radiation oncology, University of Texas, MD Anderson. Went to the clinical team in radiation oncology at Duke. Was on the pediatric breast and head and neck team there. And then left, went to the dark side, became a hospital administrator, and was a hospital administrator for Covenant Health out of East Tennessee. And I left there in an interesting fashion. I was on my way to being climbing the ladders, so they say. But I have a small problem is I don't like to play the game. And so as I made my exit from hospital administration, I mean, love the patients and I really loved what I did, but wasn't interested in. So when I left the kind of C-suite progression, the question I asked the board and the people was, hey, what was my biggest mistake? And that was my biggest mistake. They were vocal and they said, hey, you were awesome. You just never learned to play the game. And that was the best thing that they could have ever told me because that's not what I came to do. Tying that somewhat together, diagnosed, treated, and lost both of my parents, so I understand this better than anybody. My mom to a GBM, my dad to a liver angiosarcoma, so I understand this process from all aspects, from the patient, from the business side, from the clinical side. So that is a little bit of background. I've been in consulting now for since 2014, 2015. Pretty much well known for giving no tacit approval and calling it the way it is. It just is what it is. I always tell people, you're at least going to get honesty. So if you call me and ask, don't expect me to candy coat anything because that will not happen. I think that's where we are in healthcare right now. I do a lot of work with CMS, CMMI. I do some work, and you'll meet Eric. He's around here somewhere. But with the OIG and DOJ for fraud, waste, and abuse as an expert witness. Um, Sometimes doctors and providers and other people have bad behaviors, and sometimes we have to watch those behaviors. So uh, this is a pretty wide open presentation. We have the term value-based care, and I think it drives me nuts just as much as everybody else's. What does it really mean? We talked about value-based care and doing all this stuff, and meanwhile, 2.5 hours north here, where I'm from, in Jackson, Mississippi, we don't have water. Yeah, we don't have water. If you turn on the news, it's like 10 days, and it's the biggest fiasco you've ever seen. In a state capital in the United States that we don't have water, I go out I actually have water. I'm 10 miles east. But to go out and see Black Hawk helicopters flying around, I'm like, what is going on? Basically, what happened was for 15 years, the elected officials decided maintenance wasn't important for the water pumps and the upkeep. So, and then the straw that broke the camel's back was one of the floods. And so here we are. One thing I did learn though, the hospitals up there have their own wells. They can run 30 days, full diesel power. And so I thought that was pretty cool because I'm originally from East Texas and we didn't have wells. So if you don't have water, you don't have service. But they had infusion clinics and stuff with no air conditioning. It's Mississippi in the South in August, September. That's not a fun place to be. So we'll talk about some of this. What does value-based care look like for the patient? What does it look like for the provider? And what does it look like in my head? Um, is value expected? I think this is interesting because you see so many advertisements and commercials where it's like, we provide the biggest value. Listen, any patient that walks through the door expects some level of value. I think it's very interesting because the patient doesn't have like a scale in their mind. Well, if 10's the best, I'm only expecting a 6 today from you guys. Like they expect that. Yet a lot of providers are advertising. It's like that's expected. So um, this is just pretty interesting to where we are right now. Per capita healthcare spending right now, the U.S. still ranks among the highest, pretty much all over the world. Just went over $10,000. We obviously spend most of the spend is in the last 10 years of a patient's life. How do we do this? The cost control is like a runaway train. If you look at it on the graph, it's not a linear, it's more of an exponential spend. And we all know this, the spend equal quality, the more I spend. No, not necessarily. That's definitely not the case. So we'll talk about that some. Healthcare consumption, expenditures per capita in the U.S., and you can see here the consumption. Again, that same graph, a little more granular, a little closer, around 10,000, still about 11,945, exceptionally higher than anybody else. So, what is everybody else doing that we're not? And some people say they have socialized medicine. I have been around socialized medicine. I understand how socialized medicine works. I'm not saying socialized medicine is the answer. I'm saying probably all the payers that we have and every hoop you have to jump through to get a patient taken care of is definitely not the answer, and it's not working. So we'll talk about that some. So what value-based and quality care is not? During COVID, nothing will piss a clinician off more than, and guys, it'll be a little bit politically incorrect, so I'll give you your parental advisory warning before we start. What is not is a hero's work here sign. You want to piss a clinician off, that's a sign you put up front real quick to do it. If you understand anything about nurses and providers and clinicians during COVID, especially, um, it wasn't a matter of saying, hey, heroes work here and give them a pizza party and they'll feel good, right? And I can say that as a clinician. You go to work to really take care of the patients. And, a lot of people, salaries were cut, and they still showed up. It's what we do. In 2005, kind of golly, it seems like a long time ago. 2005 was Hurricane Katrina here in Louisiana, where you sit right now, was completely underwater. I was in college about 2 hours north here. We came down here the day after, day of, and we spent some time down here, and it was like a third world country. And um, nobody was concerned about the heroes work here sign. We had people going in and out of these hospitals down here, streets away from where you are now. We went in and out of hospitals in boats, handbagged patients for multiple hours. And then, of course, y'all saw the scrutiny of when we gave certain drugs to help a patient ease in their transition to death. Now, I can tell you, there's some tough decisions that are made. And to see what was done in COVID, um, that middle thing is literally almost insulting to me, because I know how much they gave up. The other things that drive me nuts is you see U.S. all these rankings like we're in the top 10, we're number one. I'm like, what's it even mean? Like, you look at your stats, you killed 44 patients last year in surgeries gone wrong. So it's like, how we did better than the other? We only killed 43. No, I don't know. That's This drives me nuts because it really has nothing to do with quality value based. You realize these are mostly like paid for. We know that, right? They look good on a sign. They look good for advertisement. They look good for recruiting. But does it actually get to the patient level? And I think that's somewhat frustrating too when you see some of that. Leapfrog came along like 2 or 3 years ago, 4 years ago, and I always used to think, I knew about the best hospitals and we knew about Joint Commission, and now there's Leapfrog. I don't know. And they just give you a simple score like A, B, C, D. So value-based care, what is value-based care? And I think this is a big, nasty transition conglomerate. Value-based care, it's confusing because it's convoluted because it has vested interest and agendas by a lot of parties. At its core, it's simple. But as you can see here, things get, the cost is one thing, right? It's the cost to provide the care, it's the cost to the patient. Data interoperability drives me nuts because we always say if we just had access to the data and we could link all these systems together, we could provide better care. Yet vendors, Judith Faulkner, I love Judith Faulkner. I'll insult her a little bit. She's the head of Epic, right? So anyway, they could give us access to the systems, but it's not. You need access, it's $20,000. You need this HL7 interface, it's $30,000. And so you have all these vendors. And so I struggle with not playing the game is you can't tell me it's about the patient and it's about the value, yet we continue to put up barriers. So data exchange is the same way. In transformation management, then we have, the risk identification, who's paying attention. Probably the biggest one is coordination of services. Um, Patients are lost in the system right now. And when I tell you lost in the system. Don't know what's next and um, don't know where to turn. They get a screening, they have a positive screening, they don't know what to do after the positive screening. They become kind of their own advocate unless you know somewhere to reach out. What are you supposed to do? I'll give you a case and I'll give you an example. I do a lot of work and I'm an advocate with the Emmerman's Angels. So I match with cancer patients all over the country and their family when they have issues, when they have problems. Probably about 3 or 4, and maybe it was 2 or 3 months ago, I got a call from somebody that had a daughter, and the daughter had a son, and the son had a midline glioma. Midline glioma in the middle of nowhere, Indiana, was given 6 months to live, non-operable, boom, nothing. I'm like, I don't know if I believe that. So I called Cleveland Clinic. I said, listen, once you guys see this, I'm going to have him come over. You see this patient. So anyway, long story short, they get him on clinical trial. They do the surgery, and he's fine now. All margins are clear. What happens if you have the inability to ask the question? Is it still value-based care? Is some care better than no care? And do we bend the rules to give people some care, even though it's what we would consider less valuable care? And I think that's a problem, right? Um, these are all things that play out in the real lives of people every day. I was a patient. I was like, I'm going to tell my story. I'm not going to tell my story. I was a patient a year ago after this conference. I spent 10 days in the hospital. It wasn't because of this conference, but I had to blah, blah. I had a small spot here, folliculitis, nicked it with a razor. Now I would have been fine had I not been about a month and a half out of COVID, thanks COVID. And then the train and the wheels fell off from there. I ended up with post-acute MRSA, 14 doses of vancomycin, 14 azosin, and it was a total train wreck. Missed doses, missed IVs, wrong dose. What saved me is a lot of people in this clinic. You'll get to meet some of them. If you know Shara Reed, Geraldine, she's here, Elizabeth, who you met. Those are like my advocates. And we're calling, talking to the pharmacist, the doctor. Like, y'all are going to kill me. Like, y'all need to get out of here. And so, but what happens if people don't have that? And so I think that's the most important thing, because that really is a part of value-based care. Because I can tell you, a lot of people still don't have, you know, access to anybody that can be their advocate, help them navigate the system. They don't have internet. They don't have drinking water. I mean, this stuff matters. So we'll talk about that a little bit more. Um, what about this? Is this value-based care? Springfield Clinic, and also, God, I'm going to have to pick on my state. The next slide is Mississippi again. We're seeing a lot more of this where insurance providers say, you're out of network now. And here's the balance, right? The hospital says we've been taking it on the chin of the provider, the clinic. We need more money from you. And the insurance company says, we're going to pay you less money. So then what happens is now you're out of network. This has gone on for over a year, Springfield Clinic. I have been involved somewhat in this. But now every patient that has Blue Cross Blue Shield that goes to Springfield Clinic is considered out of network. Yet both parties advertise on their sign, care about the patient. The patient's first. And so, same problem in Mississippi. UMMC, our largest hospital in Jackson, decided they would have a dispute with Blue Cross Blue Shield. It was literally 20 minutes down the road, and now it's been 4 months. So now, same thing. The wheels have fallen off. They can't come to an agreement. Every patient that comes in, other than emergency care, to seek care is considered out of network. This to me is not quality, valuable care, but it's becoming a problem more and more, because some of this is because of price transparency, right? So with price transparency data, we're able to see now what commercial payers are reimbursing for procedures. And so it's basically a standard deviation curve. If it's a far to the right, those payers want to pay less and try to get more towards the average in the middle. And they're going to be paying less money, yet the hospitals are already hurting, so they want more money. And then you just end up in these stonewall situations. Now, this stonewall situation went awry and has now turned into a billboard board, which is pretty interesting and funny. It's Blue Cross Blue or UMMC says, even though Blue Cross Blue Shield doesn't care about you, we still do, and they have that on a billboard outside the hospital. Blue Cross Blue Shield said that's bullshit, and I have a problem with that, so they filed a lawsuit against 4 employees personally. 2 physicians, a nurse, and somebody else for defamation. And I mean, this has turned into a teetotal, yeah. And I mean, yeah, both of us care about the patient, right? I'm like, come on, guys. At some point, and that's what really frustrates me, is our actions have to align. Like, what are we really doing? I know it looks good in advertisement and marketing, but are we really doing anything that's helping the patient, that's pushing the patient along? And this is probably not a good demonstration of that. So hopefully they get this stuff situated, but be aware that this does happen, and hopefully if it does happen in your area, that you know what's going on. Like with Einstein and Jefferson, also you'll see when two entities merge, each have their own payer contracts. Things may change, coverage may change, network status may change. Most of the time, and I can tell you in these situations, the patients, unless a lot of patients just don't pay attention to the news or anything, they don't know until they go. And then if somebody doesn't tell them, which happens, they get the bill in the mail. And then we have a whole different problem situation. That's actually starting to happen at UMMC now, is they're getting a lot of patients coming forward that said, dude, I didn't have a clue.
We seeing the same, are you seeing the same with oncologists and hospitals fighting for who's getting paid what? Hospitals want more money, oncologists would like to get paid.
So that's interesting. He asked about oncologists and payment, and I do a lot of negotiations for groups, hospitals, and oncologists. The oncology market is very interesting. There are some states where the oncologist cannot be employed by the hospital. Tennessee is one of those. Um, Used to, you had a lot of oncologists that were independent groups. Hospitals said it'd be a bright idea to employ the physician, and physicians thought, well, that's not a bad idea because it keeps my referrals until COVID happened. Now what happens is the employment model is now hostage of your salary to control costs for the hospital. So now oncologists are upset because wages have been cut or frozen. They're not getting paid what they feel. So we are seeing, interestingly enough, a drawback in some of the oncologists going back to private groups, but that model's different. So in oncology, what we're seeing is American Oncology Network, Texas Oncology, One Oncology, these powerhouse groups. Radiologists, it's RP, Radiology Partners. There are these conglomerate, massive groups all over the country, so they can try to leverage that. But I think that is, and it's not just with oncology. You're going to see that with a lot of specialties right now that employed physicians, because the hospitals, like we have a revenue problem, and the largest expense for a hospital is salaries and wages. And the faster way to get there is to cut the physicians than cut the $13 an hour employee on the front lines, even though that's who they go after first. It makes no sense to me. It's like, through productivity models, we're going to have. I'm like, what? So, but no, that's precisely that. And I think you'll see some interesting alignments of how that happens in some of those movements right now. And who gets caught up in the middle of all that is the patient. These guys, in the meantime, make a lot of money. And I'm like, I don't know if you guys would go over this, but how much these guys make. And listen, I'm not opposed to CEOs and people making money, but if you look at the quarters, even during COVID, what these people made, and now with the audits that they're doing post COVID to claw their money back and take their money back, it is absolutely insane. So these were just some of the numbers. We follow these numbers, we track these numbers pretty closely to look and see what they're doing, how they're doing. And then there's these alignments, right? So you have CVS and the Optum side. Then we have Optum and was it Optum and Change Healthcare? And we don't know how that merger is going to happen. So these mergers and acquisitions happen, and then there becomes larger controls because then they have access to the data from end to end, PBM data, provider data. And so then the question comes, like with federal trade, does it give them an unfair advantage? If you watched Amazon bought, was it One Health? So now that's come under scrutiny. If you're watching what's happening, FTC and them are stepping in and they want to review it and see if it creates a conflict of interest. Checks and balances. I don't know what you do for this right here in this problem, other than they are the gatekeeper right now, and they are not having problems in the profit department. Medicare Advantage is going to be a contributor to this. Anybody here a massive Medicare Advantage fan? I know, right? Somebody should throw somebody out. I may have thrown something at you if you raise your hand. But no, I'm a traditional, just give me my red, white, and blue Medicare card and a good AARP supplement and call it a day. That's not how they've been sold. There are massive lawsuits filed now because of celebrities that have, got paid a lot of money to advertise Medicare Advantage plans. Right now, we're seeing about a 1.8% decrease per year in traditional Medicare enrollment, while we're seeing almost a 3.2% increase in Advantage. Advantage over the next 6 to 7 years is going to run the show. And it's a runaway train, and it's highway robbery to the patient, to the providers. And we could probably have a whole nother talk, and I would like to do that. So then we talk about cost and value as we get into the health tech side and the business side and all the fun stuff. And we'll step on some toes because it's fun. And I predicted it in 2015, 2016. But so what I said back then was, listen, guys, money was free until this recession, until we had this correction. In the private business sector world of PEVC, you could go out, you could raise money. It was super simple. It wasn't hard to do. If you couldn't get $5 million for your idea, you were probably an idiot and you shouldn't be in business, because they were giving, like, if I've got a new blue flavored snow cone, and they're like $5 million, go see if it works. And so that's exactly what happened. The problem is a lot of good employees got caught up in that. And then the correction happened. And what we figured out is a lot of big businesses got a lot of money on evaluations with no revenue. And so these are some of the companies. All of AI was like the largest unicorn in probably history and won't happen again. But Sean Lane and his team raised a ton of money, and then they had 900 employees, and they cut 450 of them at the same time. And this has been about a couple months ago. Clarify Health, Cedar, Invite, Babylon Health, UiPath. The list goes on. Probably 100 plus companies that are part of this correction now, and it makes me think about value. So when they advertise in these companies, and Angie and some other people know, is when these advertisements happen, that we're gonna automate healthcare, kids. Yep, and I don't want to touch anything prior auth automated. We're going to track everything automated. It's not the way it works. And for those of us that are clinical and those of us that have been around long enough, we know that. Yet they sell these platforms to people, and we call it smokescreen software. We call it vaporware. We call it, and though they may have good intentions, ultimately a lot of these big companies, they're pushed to make money, quick exits, 3 years, 4 years, and that puts healthcare systems in a broken place. The other thing we see with healthcare systems right now and providers is they're tired of buying unique softwares that do one thing. So now I've got 10 softwares, 10 different logins to log in, and this does one thing good, but it doesn't talk to this, and nothing talks to Epic, and your server, I'm like, they're on the island on their own. And if you want it to talk, you better bring your checkbook. But again, not value-based care, and being somebody that's created software in the space. Listen, I do more creation of stuff in Microsoft Excel than you could imagine. And people are like, Excel? I'm like, yes. Like, we can't even get Excel right. Quit talking about AI and machine learning so I can get Excel right for people. And that sounds crazy, but we do a ton of work just in organizing and structuring data to make it useful. It doesn't require some AI and machine learning. Most AI and machine learning truly is at its base core is like a if-then statement in Excel. Just some other ones we talked about, waste, cost versus value. There is I don't know if the YouTube video will work on here. I could try. Eaton Health raised 60 million Series C. And then you can look at Medley Pharmacy raised 100 million in Series B, and then they same thing. I mean, upside down, start laying people off, and it's a waste. I could have thought of better places to put that money. I want to see if YouTube works. Yeah, I'm probably gonna crash this whole thing.
Creating your daily OR case assignments to the proper anesthesiologist or CRNA is.
Hey, boss, you got a second? Oh, hey, Jimothy. Yeah, what's up? Well, a lot of our customers are pretty upset about the cost of their prescription medications. Yeah, I bet. They're super high. Is there anything we can do to help bring that cost down? Oh, you're going to have to talk to the pharmacy benefit manager about that. What is that? The pharmacy benefit manager. The PBM. Jimothy, did you not study your health insurance chain of command? The PBM negotiates discounts with the pharmaceutical companies. Oh, and then they pass those savings down to patients? Oh, God, no. Ugh. No, they pocket the money, reap enormous profits, which actually increases the cost of medications to patients. Really? Yeah. PBMs run every aspect of the drug market. They set prices and they determine which medications will be covered by your insurance, all to the highest bidder. Oh, God. Well, do you know where I can find one of these pharmacy benefit manage? What's happening right now? Hi, I'm the pharmacy benefit manager. I'm confused. Jimothy, it's actually me, United Healthcare. Yeah, I know. You're also the pharmacy benefit manager? Yeah. Well, we go by Optum, but it's all United Healthcare. Anything else you own? Oh, we have our own pharmacy, Optum RX. Yeah, all our customers have to use it. It's great. So let me get this straight. The PBM, that's me, decides which medications are covered by health insurance, also me, and which pharmacy, me again, the patient uses to get those medications. Vertical integration. We make $200 billion a year. It's awesome. Surely there's some kind of oversight, right? Somebody has to keep you accountable. You don't make $200 billion a year with oversight. How is any of this legal? Jimothy, when you make enough money, you get to write the laws.
That's it, man. I will send that to y'all. So do y'all know who that was? That's that doctor, glaucoma flocking or whatever his name was.
Knock, knock. Hi, I'm the new med student.
That's who that was. And so I'll make sure you guys actually get that and I'll send it over. But that was probably like the best one because it literally shows like they're not in it for value, guys. They vertically integrated it all the way through, and they know it better than anybody. And they have the money, they have the power, they have the network. So and unmonitored, like he said, they write the rules. So all right, let's see if I get back on track here. So buzzwords that drive me absolutely nuts: population health, social determinants of health. These have all like these words have been around forever. Why are they so like the fluffy buzzwords now? Social determinants of health bother me, guys. I do a lot of research. I publish research on price transparency, access to care. And I live in Mississippi, which is next to Louisiana. We gang up together and pick on Alabama. But we are number one for a lot of things: obesity, teen pregnancy, drug use, crystal meth. I mean, all the good things, diabetes. Pretty much number one. I mean, you got to be number one for something. Might as well be something. I don't know. Louisiana, so we're the same way. So talk about social determinants of health really pisses me off. There's only one. It's income. Period. End of story. There is no other social determinant of health. I don't care what textbooks say. Drives me nuts because there's lots of good health care. If people can't afford it and get to it, it doesn't matter. And we see that in Maryland. Maryland has like Chicago's the same way where they have a lot of good hospitals. And now there's studies coming out, if you've seen them, where you can cut New Orleans where we sit today, and the life expectancy changes by 20 something years based on what ward you live in. It's just facts. It's just the data. Can't argue with the data, and it's a little disturbing because we have good health care. You just can't afford it. And screening is another thing that bothers me. Like we're going to set up a screening program for people, man. You know what happens? The patient's like, okay, then I get a positive screening result. What do I do now? So we call that screening abandonment. Drives me nuts. Also, there's a book. Um, it's the title is rough, but it's spot on. But it's called "Mama Might Be Better Off Dead." It's in inner city of Chicago, and literally a lady that is going through dialysis, and what it takes for her to even get dialysis is absolutely insane, and missed appointments, and and so it's tough because a lot of private equity PE, VC have tried to now enter the market to make a lot of money off of social determinants of health. There are people in it for the right reason. Precision medicine is another thing that drives me nuts. Financial toxicity. I love financial toxicity talks. They fire me up. I do research out of Memorial Sloan Kettering with Dr. Chino there, and it's real. Most patients, I will tell you, and you saw this get exploited in COVID, people are like, well, I just don't understand why you're non-compliant on your meds. It says take it every day, and you're taking it every 3 days. Food, safety, shelter. Maslow's hierarchy of needs always hold true, and that's what you see now. So people are not going to rush out. And Angie, this patient oftentimes will ask us, how much is this going to cost? My mom's biggest concern going through treatment was leaving me with debt or being a financial burden. Being patients care, they want to know, and oftentimes it's not for them. And they're willing to take the bad side just to not be a financial burden on somebody or have to make decisions. Um, so again, health equity, we talked about that. Some AI machine learning uh, drives me nuts. Like we talked about that. Equitable care, and then real world data is another big buzzword. I'm like, isn't all data real world data? Like we're in the real world? I don't know. It just sounds cool, but I don't get it. So for me, the key is if you're going to talk about that is really relational data. And that's where we've had a big gap. So we're looking at data that's important when a patient comes in, their financial, the workflow, the outcomes, tying that data together that all lives in different silos. That's relational data. And that's really where value-based care will reside as we move forward. So failed initiatives for providers. Anybody here familiar with like macro MIPS? Those were a pain. And they told all these doctors, you're going to make all this money. And it cost them $30,000 to implement. They got back like $5,000. I'm like, come on, man. And then all this quality crap, and I know because I did this as a director, became like check boxes, right? So surveys that you filled out that really didn't have anything to do with your patients or your service line, but it was a requirement. And so then we're just checking the check boxes. Employment, we talked about that a little bit at the beginning. Is does it make more sense for me to now become an employee? Now probably not so much so as it did maybe 5 or 6 years ago. The risk has always been assumed primarily by the provider and by the patient. Now we're seeing this like two-sided risk models where we feel like some of the vendors need to take some of the risk. Fee for service, it's hard to. We built the whole system on quantity, right? CPT codes. We're going to bill for every CPT code. Fee for service is hard because we then have to build what's called total cost of care models. We were back in the back of the room talking, and so when you get those prior authorizations, there's no CPT code for it. When you do that stupid appeal for the third time, not one. That peer-to-peer, there's not one. There's so many things that we do inside the clinic that don't fit a fee-for-service model. How do you want that in? And so we do that. We look at a lot of that. What is the time cost? That time? How much is that employee making? What computer programs are they using? We try to figure that out, and that's really got to be accounted for. That was one of the big reasons CMMI fell with the radiation oncology alternative payment model. We have a new model called the EOM, Enhanced Oncology Model, which is a continuation of the OCM. I don't think that model's going to go very far. It's voluntary. A lot of people might just be signing up for that. Like, sign me.
Yeah.
Oh, exactly. And if you did the OCM, and some people were profitable in the OCM, Texas Oncology, McKesson, One Oncology, those guys are. So for them, they're probably going to do it because they're like, we invested 5 years to try to make this work. But I just don't see people jumping in that have never done it before. The EOM is a tough model. Geography matters. Age matters for getting health care. Crazy things happen. I'll give you a story. I got to leave a little bit early. I was going to say it was Saturday. I got to leave Friday. I got to go to a funeral on Saturday. I've got a family friend. She's a well-known OBGYN in Indianola, Mississippi, which is kind of up in the Delta, middle of nowhere, but she is amazing. OBGYN. She was seeing patients 2 weeks ago, went in a week and a half ago, had some chest pains, nausea, just weird symptoms. They diagnosed her immediately with acute promyelocytic leukemia. Started the arsenic, which is the typical chemo regimen. Threw her into 1, 2, 3 back-to-back trifecta strokes. She died. She was 46. So I'll be going up there on Saturday. So you think 46, young, healthy. She was fine, seeing patients before. It all happens quick, right? And we don't know. I hear these stories more and more often. And then my thing is, what if they can't get to the drug? So they're immediate. She's a physician. In the beginning, she knew what was going on as soon as they diagnosed her. She didn't have a clue about the drugs. She's like, I'm OBGYN. I don't know anything about these drugs. But there were several different drugs. So I think be careful with age because we used to think certain things happen at older ages. That's not the case as much anymore. So we try to look at that from a value-based perspective. Income, we talked about that. That is the number one social determinant of care. Education, COVID messed that up. That'll get exploited even more. And then payer mix matters. Listen, nobody's going to build a big hospital right now in the middle of a Medicaid self-pay area. It's just not the way it's been done. So when we talk about how do you really fix healthcare, I can really fix healthcare. I don't think a lot of people will want to get on with that, like get on that train, but nobody's rushing to those areas. Hospitals were primarily built in those service areas, especially now if they do it, they try to build with a higher commercial payer mix, right? If you were any kind of good financial planner, one of my CFOs when I was a hospital administrator said you better learn to run your service line, your hospital off of Medicare reimbursement. Now you're starting to see used to commercial payers average 54% out of Medicare. Now it's down to about 226. It'll continue to fall down as commercials lower and lower based on that price transparency data, making it more tough. We don't simply just print more, patients. It doesn't happen, especially in oncology. Somebody tell me maybe they should bring back those like cigarette vending machines. It's horrible, man. Something do that. But payer mix is absolutely tough because if you are primarily Medicaid, and you know this, if you're uninsured, how do we get people enrolled into TennCare, into Medicaid? That takes time. It's not always, approved right then. Are there programs out there, and I know a lot of you in here, I know Lori, Angie spend a lot of time, and they have staff that spend a lot of time searching for these patients. And you guys, you two, I know a lot of people in this room do that, but you two in particular, and anybody that does that work, I'll tell you this, man, you're doing God's work for sure. I mean, because it's not easy. I mean, I get the phone calls and oftentimes end up calling you guys when patients call or I get the call. It's like, what do I do? I don't have any money. Is it automatic death sentence? We got Jared at $4 who's trying some stuff. Jared Walker that tries some stuff. But I think when the business is involved in healthcare, it makes it tough. Like I said, we want to build these new facilities, but if they're in these primary areas, again, New Orleans is a great example. We can take you down to some wards later on this afternoon that you go into those places and you think you're in a totally different world. Geography, where service happens, hospital versus freestanding clinics drive me absolutely nuts. This is a study at Texas Oncology, Dr. Deborah Pat, who I do some work with. We did, and we looked at cost of drug versus the drug versed on service day versus on service at full course for infusion for chemotherapy. And you can see here, obviously, side of service in the physician office ended up being less expensive. Now, I'm not going to, we won't pick on hospitals because I came from the hospital environment, but the question here is if we've proven this data, how come CMS, and this is a question among questions, continues to incentivize the hospital? So we look at 2023, physicians are looking at a 4.2% reimbursement cut, yet hospitals are looking at a 5% increase. But if we know this data, why does this keep happening? There's several theories, guys. Obviously, we control more if it's run through the hospital. There's some 340B questions there. I know 340B is, I don't know what's going to happen. I think it's still around for a while, but I think that has gone off the rails for sure. But, side of service matters for cost. Now we have a lot of insurance companies that say, especially for advanced medical imaging, that we're not going to cover it in the hospital. We're only going to cover it in an open imaging center or an IDTF or something like that. So now they're starting to dictate, but it's still counterintuitive to what CMS has proposed for 2023. Some of the supervision rules will change that have been proposed for 2023 that will make things a little more interesting for the hospital side of service. Any questions on hospital side of services or anything? Versus sure.
Do you think that it will make any difference with the value-based care that hospitals come up with, like one bill instead of sending 3 and 4 separate bills out? Do you think it would be better if one universal bill was sent out, they get money, then they split it up and gave it to me?
She'll let you answer that, Angie. I absolutely think that would be, but the biggest confusion a patient has is, so they'll get a bill from the hospital and they get a bill from the physician. What the hell is this? I saw the doctor in the hospital. What is this? Now I have 2 bills. And that is very, very problematic because they don't understand. One was billed. Listen, I'm not explaining to a patient. I will explain it, but I don't expect them with all they're going through the stress to understand, well, this was done on a claims 1500 form and this was done on a UBO 4. And you need to understand that they back bill, that they send the bill out every 30 days and the doctor bills. Like, no, if we could simplify, and I think that's the issue that I have. We're trying to come up with these miracle solutions. We can't even do the simple stuff first. And this is driving me nuts because it's like these are the simple things that would make a huge impact. Let the hospital split it up on the backside. So for a freestanding clinic, if they deal global, that's exactly what they do. They split up the technical and professional on the backside. And so that makes sense to me. I think the side of service care, I'll tell you what's fixing to kick a lot of people in the teeth too is home care. Baby, care is going home. And you're going to see more and more of that. Some of your big hospital systems have already built models. UPenn has one. I think TJU does too, that they're experimenting with some of the. And I get the arguments. Well, what if it's, not a sanitary environment and safety of the nurse and temperature of the drug? Guys, I've worked with these people. I've worked very closely with these people and understand. I just think it's going to go there. I think I didn't need to spend 9, 10 days in the hospital getting vancomycin and Zosyn. I think I could have gotten it at home.
There's
I want to say this. I think it all goes back to contractants. I think total site of care is silly in a sense of Jefferson Health or the Philadelphia region. One of our biggest payers, IBC and Aetna, they decided certain drugs were going to be, have to be on the office side. And what did IBC come to Jefferson's contract and legal department say? Well, it's fine if you bill it. Can't be on the hospital side. Flip it to the 1,500. We're only going to pay you what we would pay on the professional side. So just go back to the contract. Let it be done at the outpatient hospital and say this is the most you're going to get. The most you're going to get is the professional side. It's so tedious to get the authorization on the right side, to make sure it gets billed on the right side. When at the end of the day, IUC is giving our blessings to say, we know what really happened in the outpatient, but go ahead and flip it.
It's first, so Angie's right. I mean, it really happens at the contract level, and it turns into this cat and mouse game. I don't know if I wind. Give me 2 seconds, and I'll grab you. 2015 is when a bunch of practices, when the pendulum swung and hospital reimbursement became higher, and a lot of the freestandings were like, heck yeah, we're fixing to switch to hospital based, and the government said nope. November 2015, that was when we had the grandfather based rule for a hospital outpatient department, HOPD, and then they said, well, technically you're considered on campus if you're 250 yards, and then the lawyers got in, is it 250 yards doorknob to doorknob or property line to property line? I know because I sat through some of those, and it's mind numbing. And now, certain if they use the PO modifier, you're only going to get, so then you're only going to get at best freestanding reimbursement, even though you're an HOPD. And that happened back in 2015, and we're still feeling some of that. But it really happens at the contracting level. And I think it's to be able to get to that level and have the right people at the table to be able to negotiate that contract. And that really is where the value based care will end up starting, is with the payer, because you can make it a win for the payer. I think a lot of people think there is some give and take that you could do, because I mean, if I'm looking at some of this rural healthcare stuff that we're doing with remote patient monitoring and some of the different stuff, if I can keep a patient back out of the hospital, there's a huge gap in oncology for transition care. Patient finishes treatment and goes home. There's a huge gap. If I could find ways to help manage that and keep them from going back in the hospital, payer saves an enormous amount of money. The hospital saves money.
I was going to actually talk to you about what you were presenting just now, but in regards to what you were saying, one of the great examples of this is North Carolina Health System. So they have 900 beds there, but 1,000 administrators are involved in billing, right? So 900 beds, but 1,000 staff dealing with billing and administration of the health system. But I was going to ask you about, like, are you familiar with site neutral payments?
Yeah, site neutrality. That's what killed our ROAPM model, because we had so many, freestanding clinics versus hospital, and they wanted to try to get site neutrality. And getting site neutrality for a physician MPFS freestanding compared to a hospital is almost impossible. But site neutrality, I mean, if you could do it, and I think it can be done. They did. But who's the enforcer, though? So we saw that, right? And that's where the issue is. They told us a year ago on January 1st that all the hospitals were supposed to publish their pricing. And you see how that worked out. I know because I ingested all 5,234 hospitals, of which only half had data, and half of that half only had data that was readable and applicable. And we've penalized 2 hospitals, both north side, both low penalties. And it's like, if there's no accountability, we can't move that forward. And patients aren't going shopping off that data. And I tell people that all the time. I wasn't worried about the shopping. What I was worried about it was from a contracting perspective to look at what some of these people are getting. I can tell you right now, there's 2 hospitals in the Northeast. We'll pick on Philadelphia for a little bit, UPenn and Thomas Jefferson. And those hospitals, for a course of radiation therapy treatment, it's 496% different between 2 hospitals that are 15 minutes apart. The exact same course of treatment, using the exact same equipment, the exact same physicians, all the variables are the same. Yet one is negotiated totally different. So to your point, site neutrality.
Let's say 80% of the hospitals in this country are losing one grade. And the ones that are profitable are just in the single digits. And when you look at the policy changes that are happening with regards to, like, let's say the inpatient list, I don't know if you're familiar with the inpatient list, but they're not going to allow admissions at hospitals the way they used to.
Talking about like the IPO, the inpatient only list.
They're not getting allow for admissions. It's not going to happen. It's going to be right. It's not there.
Well, and we know in that IPO and the observation, a lot of that could have been done at ASC. Send them to an ASC, send them to an independent surgery clinic, and be done, because it didn't need to be done in the hospital. But they hung them in the hospital for exactly that reason. I remember the old rules, like the 2 midnight rule and all that stuff. It's like, oh my gosh, man! Like, some of this is archaic. No, I agree with you.
They have to change the mind. Like, if you look at right now, urgent care centers are kind of going away.
Yep.
Right? And you're going to do outpatient surgery centers. That's where the investments are going to be on the health systems.
Absolutely. I mean, that's where all your investments.
Internet. There's no more 5,000, 15,000 in that.
The Medicare reimbursement, I mean, you can look at this graph, see where physicians are pretty much plateaued since 2001. This is Medicare pay compared to inflation, basically, and you can see how it kind of flatlines. I think this one was produced by may have been the AMA. I know the Federal Register Medicare trustees has their tag on the bottom there that we look at, and then several of us got together and did a New York study. I presented this at ASCO with several physicians, and we looked at Pembro, the price variability of Pembro in New York among, I think this was 5 hospitals or 6 hospitals, and it was all over the board versus charge versus what was paid. How can this be in such a small area? So we presented this data. We're expanding this data to come out in 45 days. It'll be presented I think this will be presented at Astro, that will present where we took all 65, 66 NCI designated cancer institutes, which, just a funny note, by the way, there's 65 designated NCI cancer institutes. Of that, less than 10 have complied with price transparency rules. Of those 10, and then, PPS exempt hospitals, there's 11 of them. They get a lot of money over Medicare allowable. MD Anderson, Moffitt, they get like 30% plus Medicare. None of them have published, and it made it very well known that they will not publish their price transparency data. So, to your point, until we have some level of accountability, and we've all written CMS and CMI and said, guys, don't pass a rule if you're not going to enforce it, because we can actually do stuff with this data that impacts patients. And I think that's where we're in limbo right now. But if we can get some of that, we can look at some of these studies and change some of this. This is 96413, chemo IV infusion, 1 hour. 2022 on the left of the x-axis, dating all the way back to 2010 on the right, and you can see at a global it's pretty flat. And then at that hospital, it used to be less, and the hospital keeps increasing. It was increased in 2022. So, if you look at it, I always say this is my dyslexic graph I did. I probably should have done it the other way on the x-axis, but you can see, hospital continues to increase while the freestanding bill and global just kind of flatlines. If you ever wanted to know what the highest place in the U.S. for reimbursement is, it's Vallejo, California. The lowest is not Knoxville, Tennessee, pretty close. It's actually Dothan, Alabama. But when you go to a vendor, you don't get a Dothan, Alabama discount. They probably charge you more. But that's the problem, and we talked about is, why is it so different? And we get cost of living differences and stuff like that. But these are just some of the numbers, and some of these are just astronomical that we look at. So, like for self-pay rates, max rates, and things like that. And we publish a lot of this data. We've ingested a lot of this data, and some of it's just it's mind blowing. And I guess you could say, for a hospital, good for you, you negotiated a good contract. But for site neutrality, when we can't say just Medicare only, So it bothers me when we say we're only going to do this for Medicare. We know Medicare is continuing to decrease. Does anybody have leverage for the commercial payers? And that's going to be the issue: is can we pull some of this together? So really the keys to this whole trainer is care coordination. I think we've got to get better in care coordination. The question will be is who pays for care coordination. So we've got to figure that out some. Interoperability, we talked about the data, continues to be one of the bigger problems. Patient engagement, you can't just tell the patient what they need to do. They need to know how to do it, how they can access. Total cost of care models, if you need help, call somebody, call me, call somebody to look at what all are you doing in your department that's costing money that you don't have a billable code, you're not being reimbursed for, but how do we factor that into some kind of total cost of care model that we can then roll out? Value-based insurance designs, cost of care accountability, simplify models. One of the big things that I've seen you guys make and help me on this, I see all these companies coming out now and they're like, sign up with us. We're going to help patients. So we're going to get you, the employer, to pay us as a company, and we're going to be any of your employees advocate to go through. You know what I'm talking about? You see all these companies. It just seems really weird to me. Like I don't know really what they're achieving besides making a lot of money off of the system, but it just seems like an opportunistic. I mean, and maybe I'm wrong. I don't know, but it's like as an employee, they advertise, with our help because we're going to get you these specialty navigators. I mean, yet the patient still has to pay for it to sign up, but you'll be able to get back to work sooner, get better sooner. And like, is that the employer just looking out after themselves? I don't know how much value there is there, but I know there's a lot of those companies that have come out of the woodwork in the past few months. So any questions, comments, concerns? It's a lot of stuff. Hopefully it's a little higher level look. Go ahead.
So I was gonna say, like, I'm not as familiar with how the payment models work on like the specialty side of it. But on the primary care, like I own a practice, it's a house calls practice. We were part of the Independence at Home model, which was the most successful demonstration in the history of Medicare. So we managed around 16,000 lives, saved over 52 million. They gave us a bonus check of $22 million. Now we're going into a direct contracting model. So with the direct contracting model, we do the diagnosis on these patients, we have an assessed value on these patients. They give us a check of between, for those patients we take care of, $35,000 to $45,000 per patient before we even start care, right? So we can do a partial risk or full risk. And I can, I present on these things sometimes, but we're learning with alternative payment models that if you're in a fee for service model, you're never going to be profitable. So as soon as it went to value based, it's all about gain share and shared savings. So if you can reduce the spending per beneficiary, that's where your cut comes from. You have to do everything in your capacity to reduce the cost of the patient. So I've had meetings with like Blue Cross in Illinois, which oversees 5 states. I've sat in meetings with them, and there's been scenarios where a patient may start getting admitted to the hospital, and they would call the patient and say, "What's wrong? Why are you going in?" I'm depressed. Well, is there anything we can do to get you out of depression? Well, I don't know. Is there anything? Well, I was going to learn how to play guitar. So Blue Cross bought her a guitar and guitar lessons, right? There was another patient started going in, having issues. Well, what's going on? Why are you declining? Why are you going to the I can't afford cable anymore. This TV show, I can't watch these. So I panic attacks. So Blue Cross paid for her to have cable the whole year and said, we'll continue to do whatever it takes to make sure your costs don't go up. So when you think about value-based care, this is what they're talking about. Like University of Illinois, for instance, they have about 400 patients that are homeless in that area with sickle cell. They said, we don't want these folks coming in. What do? We're going to give them housing. We're going to build a building for them, give them all the food that they need, and see if we can stabilize them, because that is cheaper than them going to the emergency, right? So when you think about value-based care, it's really a reverse model.
It's a paradigm shift in thinking, and most people can't get over that.
Yeah, you can't go from a fee for service to value based, because now your profitability is all tied into reducing the cost. There's no profits if you're, because the more you do, the more you lose. That's what healthcare. I've had meetings with CEOs of hospitals. They didn't understand this. I was having these conversations in 2012. I would tell them, you guys are all going to get fired.
Well, that's the problem with like med schools, not teaching the really precision. They're teaching shotgun medicine now, and so they're in that model. They're going to fail because every patient gets a CT, every patient gets an MRI, full battery of tests, and so cost spend for that patient's care is through the roof because they're not doing. It's not an evidence based approach anymore. It's more that shotgun based approach.
In the hospitals, you got to remember, are structured fee for service, right?
Sure, they are.
They invested everything in doing more and trying to make more. But now it's reversed. So it's like, how do you shift from the fee for service to value based? And I can tell you, I've had meetings with executives at hospitals, and they want a lot of infighting going on between the person who's in charge of the ACO and the doctor or the president of the hospital who's in charge of filling your beds. So do you fill the beds or do you keep them out? And that's a big struggle, Bob.
Well, I mean, hospital administrator is going to say, I don't care about my staff. I don't care about, I'm filling it to the max. I'm getting paid for, butts in seats, butts in beds, baby. What you got?
I'm just gonna say, I think on top of all this, because you think about the comment about getting a guitar or cable, healthcare literacy is at an all-time low. Right, so our patients, as you're reported, they don't know until they go. They don't know anything at all. As you were all in here earlier with Elizabeth, talking about the lack of knowledge and the need to educate patients clinically and financially,